ทุกท่านนะคะกลับเข้าสู่ iAOC Course Series นะคะ Special Edition Professional Development in Advanced Imaging during COVID-19. Good evening, Dr. Wu. Nice to see you again. You should unmute yourself first. So welcome everyone to weekly iAOC Course Series Special Edition Professional Development in Advanced Imaging during COVID-19. Today we are on Module 5, Pediatric Neuroimaging with the collaboration with Riley Children's Hospital, IU School of Medicine, Indianapolis, Indiana, USA. And on week 3, we going to talk about the diffusion weighted imaging in clinical practice. What should we know and how to imply or how to use DWI in clinical practice. And we have Dr. Isaac Wu, one of the most popular attending from Indiana University and also in Thailand. สวัสดีค่ะสวัสดีค่ะสวัสดีค่ะ So you are going to teach us about the diffusion weighted imaging. It's like some physics and also clinical aspect on this thing, right? Which is probably good stuff for radiologists and also technologists and also clinicians to understand the basic principle on this thing.
That's my goal. I hope so.
Okay. And you said you mentioned that today we are going to have interactive session. So everyone should be ready to have your cell phone on your hands. Make sure that you have cell phone because we're going to have interactive session by scanning the QR code using your camera on cell phone. So we can do some interactive session across the time zone, like Thailand and USA, Indiana. So please welcome Dr. Wu, one of the most popular lecturers, teacher who has a fan base in Thailand. So welcome, Dr. Wu.
You're too kind. Thank you, Dr. Tanya.
Yeah. Yeah. Okay.
I think I'm going to share the screen.
Please do.
So screen one here. See, can you see the screen okay?
Not yet.
Oh, not yet. Let's see. Let me try again.
So you know what? This month, in 2017, you were in Thailand for the first course of pediatric neuroimaging.
Is that right?
Yeah, it's like October 7 and 8 that we had the first pediatric neuroimaging in Thailand.
It's been
just popped up on my Facebook and wow, it's 3 years already.
Time flies. Okay, let me try this again. Share screen, screen one, share.
Yes.
Okay.
That's work. And you can
you see that okay right now?
Yes, that's work.
Okay. So that's working and everyone can hear me okay?
Yes.
Okay. So let's just get started. So good evening from the United States, Indiana, and it's good morning in Thailand. So thank you very much this morning, waking up early to learn about diffusion. Thanks, Dr. Subaku again, and IAOC for the invitation to let me talk about this topic today. So let's get started. I like to start with a case approach. I'm going to show you a bunch of cases, and in between, we're going to talk about some diffusion, some of the applications, and also some of the physics behind it. So hopefully you have a very, very strong coffee this morning. So let's start with a case. You can see on the screen here, for those of you who do a lot of neuroimaging, radiologists, neurologists, and physicians, that if you see a lot of stroke imaging, you know that a lot of time, the first thing that we do is CAT scan, CT scan. This image right here, you have a CT scanner with a 40-year-old person comes in with an acute left-hand weakness. So stroke-like symptom. But I bet it's very, very difficult to find the pathology on a non-contrast head CT. If you can see this, you have a very, very sharp eyes because I did not see it. But if you do diffusion weighted sequence, DWI, the pathology is very easy to see. So for those of us who do a lot of neuroimaging, we know that diffusion weighted sequence is very, very powerful stroke imaging. In this case, you have the involvement of this place called hand knob or the precentral gyrus, the motor strip. And as you remember from medical school, that corresponding to the area of hand motor region. That's why the patient has a left side weakness. So that's what we're going to talk about today, diffusion. So I'd like to start with a interactive section just for the test. Can you take out your camera and you can use your camera, the cell phone camera, point to the screen, the QRC code. And I just want to find out about who you are. Are you a neuroradiologist or are you other radiologists, but not neuroradiologists? Or maybe a resident in training? Or are you a technologist? Or you're doctors from other fields, such as neurologists or other specialty, or are you medical students? Or maybe you're not even in the medicine, just curious about wanting to learn diffusion-weighted sequence. So I'm just curious to see, I don't know if anybody is able to log in. So I see some response, so I know it's working just for the test, and I can show you the result here. You can see that we have quite a bit of radiology resident today. And welcome everybody. And also for those who are interested in learning about radiology, also welcome to this lecture. So throughout this presentation, I'm going to show you some you see, if you see this code right here on the screen, please use your camera and we'll try to make this as interactive as we can. So good. So let me show you another case, again, stroke imaging. On this exam, the finding here is better seen than the last case, but it's still not that easy. So this patient comes in with acute right side weakness. Again, acute stroke-like symptom. I bet the first thing catches your eye is you see a dense MCA, middle cerebral artery. So that's referred to as a dense MCA sign. And if you look very closely, you can see one large area that has loss of grade 1 matter differentiation. It's not that easy to see, especially if your window is not, if you cannot window it correctly. But you can feel the subtle loss of grade 1 matter differentiation. And if you look closely, compared to the normal right side, you can see a insular cortex. So the so-called insular ribbon is intact. If you compare that to the other side, the insular ribbon is lost. So you have a loss of insular ribbon sign. So combining with all the finding, and if you also adjust your window more tightly to the stroke window, now you can see one area that has a loss of a grade 1 matter differentiation. So with everything combined, the dense MCA sign means that there's a acute blood clot in the left middle cerebral artery that's causing patient symptom. As you know, our definitive test for acute infarction is going to be diffusion-weighted sequence. So for diffusion-weighted sequence, if it's bright on DWI, dark on ADC, you have acute infarction. This area, of course, on your report, in the radiology report, you call this area restricted diffusion. And the clinical interpretation is that that equals acute infarction. So let's talk about restricted diffusion, diffusion-weighted sequence. Let me ask you another question. So you know that in a setting of acute infarction in adult, you will see restricted diffusion. The question is that how long do you think the restricted diffusion will last? How long does it take before you disappear? So how long does it last? So restricted diffusion, can you see that only in the first 24 hours? Or maybe you can see that up to 5 days? Or maybe you can see that in up to about 7 to 10 days. Or maybe it will last more than 3 weeks, or up to 3 weeks, or 3 months. So what does everyone think that restricted diffusion, how long does restricted diffusion last after acute infarction? So we have lots of response. So I'll give you 5 more seconds to think about this. So this is an important concept for the radiology residents and people learning neuroradiology. Here is a result. You can see that most of you pick 7 to 10 days. and some picked up to 2 days, and very good. Nobody picked more than 3 weeks. That's a good answer. So the answer is you're correct. It's about 7 to 10 days. So just keep that in mind. When we say there's an acute infarction on our report, this restricted diffusion with acute infarction, this can last up to 10 days. So for the clinicians who are listening, just because we say this restricted diffusion equals acute infarction, doesn't mean that the stroke just happened. Sometimes it can happen more than a few days ago. So restricted diffusion. Now, when we talk about restricted diffusion, what does that mean? What is restricted? Also, what does restricted diffusion mean compared to what, right? So what we're saying here is restricted diffusion of the water molecule, or the proton in the water molecule in this area has restricted diffusion. And also, this area has restricted diffusion compared to the adjacent normal tissue. So restricted diffusion of water molecule. So let's briefly talk about the history of diffusion here. So we talk about diffusion all the time. The story starts off with this person. His name is Robert Brown. Now, this is probably somebody that you never heard of before. I have never heard of this person before, but apparently back in his days, in the early 1800s, he is a very famous scientist in Scotland and in Britain. He's a cellular biologist. And here's a portrait of, in 1807, of people who are the so-called men of science, people who are important at that time. You can see Robert Brown is in there. And there are also lots of famous names that you recognize, such as Dalton from the atom and Watts from steam engine. So Robert Brown was a famous scientist at his time. He's a cellular scientist, or he's a cellular biologist. So at that time, of course, the thing that he's interested would be plants. So microscope was just invented not long before that. So a lot of people would start to discover, they would look at different specimens under the microscope. So for Robert Brown, he would take pollens and he would look under the microscope. But to his surprise, the pollens are not stationary. They start to move around in the sample well. And he observed this motion, and he also noticed that the motion is completely random. He cannot predict. Initially, he thought that maybe there's some type of force, a life force, or maybe even sexual attraction that's causing the pollen to move around. Then he also realized that other substances like dust, inorganic substance, also had this very random diffusion or this random motion. He could not figure out why that's happening, but he makes the observation and he publishes the result. So at that time, it was named after him. So they call that the Brownian motion. So for those of you who look at diffusion from the textbook, the term Brownian motions probably come up in your textbook. This person, of course, required no introduction. It takes almost more than 100 years before somebody starts to explain why you see this random diffusion or random movement of this substance in the sample well. So in 1905, of the 4 major papers Albert Einstein published, one of them deals with Brownian motion. So he came up with a hypothesis that it's not the pollen that's moving, but it's carried by small, much smaller particles, such as water particles, water molecule, that's in a random motion, constantly bombarding these particles, making them moving in a very, very random, unpredictable direction. So this is diffusion. And he even came up with an equation that we still use today, a modified version of the equation. And that's diffusion that we see today, the diffusion of the water molecule. And then we see that in radiology, and it translates into something that's bright on DWI, diffusion weighted sequence, and dark on ADC map, apparent diffusion coefficient. The key point here is that there's a restricted diffusion, but the restricted diffusion can last anywhere between 7 to 10 days in adults. So it does last for a long time. So that's diffusion. Now, we know that acute infarction causes restricted diffusion of the water molecule. But the question is why? Why does acute infarction cause restriction of water molecule. So there are different theories that can explain the phenomenon, but I think one of the things that we all agree on, we think contribute to it mostly is due to the failure of sodium-potassium pump. What are those? You have to go back to medical school, biology days, and remember in the textbook, we look at the cell membrane. You have an extracellular environment and intracellular environment. And remember that there are multiple active pumps that's embedded within the cell membrane. And their job is to pump out 3 sodiums and let in 2 potassiums. In the process, they will use up ATP to ADP, causes energy, and that will also pump out the water. If you don't do that, the water by natural gradient, passive gradient, we want to come out from the extracellular environment back into intracellular environment. So you need this active pump to pump the water out. So what happens when you have acute infarction or ischemia? The first thing that would go dysfunction is going to be this potassium pump, sodium potassium pump. By doing that, now the water starts to rush in from extracellular environment back to intracellular environment. And that's the beginning of the restricted diffusion. So another way to present this, and if you look at this cartoon, let's pretend that there's a very strict 2 compartment that's completely separate. One is intracellular environment, one's extracellular environment. And you can imagine now the water molecule in the intracellular environment, their movement, their diffusion are more restricted because they're restricted by the cell membrane. Also within the cell, it's much thicker environment. You have organelles, you have mitochondria, you have everything that's much thicker. So you have a restricted diffusion of the water molecule compared to the extracellular environment where the water molecule can freely diffuse around without much restriction. So intracellular water has more restricted diffusion compared to extracellular water. Now, if we take the average, let's look at the whole thing as one sample, compare that. And at this point, let's pretend that they are equal in number. In real life, that doesn't happen, but let's just pretend, just for illustration purposes, that you have a certain amount of intracellular water versus extracellular water. And at this point, they are balanced out. So let's call this sample right here diffusion neutral. So there's no restricted diffusion or there's no increased diffusion. So acute infarction occurs. Remember the first thing that goes out of those active pump. So what happened now? Now you have all the extracellular water start to diffuse into the intracellular environment. So the ratio of the intracellular and extracellular water has changed at this point. Furthermore, as the cell begins to swell up, the extracellular environment also gets crowded out. So even the water in the extracellular environment is going to experience more restricted diffusion compared to the adjacent normal tissue. So on average, this sample shows a lot of restricted diffusion after acute infarction. So that's why we see bright on DWI, dark on ADC. Okay, let me show you another case. I'm going to show you 3 different patients, and all 3 of them with a diagnosis of stroke. All 3 of them had stroke, but the timing is different. Are you able to tell me between patient 1, 2, and 3, based on the imaging characteristic, which one is the newest, which one is the oldest infarction? So between 1, 2, 3, is 1 the newest, 2 in the middle, and 3 is the oldest, or is this one the youngest and this one's the oldest? What do you guys think? So timing of the infarction. Or maybe you cannot tell. Maybe there's not enough information to tell the different setting. I don't know if the code is working. My website seems to be freeze a little bit. Dr. Subaku, are you able to see the QVC codes working?
I can, and I already answer.
Your answer, okay.
Uh-huh.
So there's only one response, so coming from you. Very good.
Is that the wrong answer?
Oh, actually, no, sorry. There's actually 13 response, 13 answers. I don't know why this graphic is showing only one, but correct. Very good. It's a correct answer. So it's 1, 2, 3. So what are we seeing here? So we have a diffusion weighted image on the top and ADC on the bottom. As you know, when you have bright signal on DWI, dark signal on ADC, you have restricted diffusion. That's acute infarction. In the next stage, you can see the DWI is going to be bright, but the ADC is normal. But we know it's not normal because DWI is bright. So we call that pseudo-normalization. So ADC pseudo-normalization, that's subacute. And in a chronic phase, you have a signal that's bright on DWI, bright on ADC, that's called T2 shine through. So that's a chronic phase. So what happened here? So here we have restricted diffusion. Remember, right after infarction, you have a lot more intracellular water compared to extracellular water. Then the tissue began to draw extracellular water from vascular space into the extracellular space. So now you're going to increase the amount of extracellular water just by a little bit. You're still going to see on average, the whole sample is going to show restricted diffusion, but you're going to draw more vasogenic edema coming from vascular space. So you'll increase the extracellular water to the point maybe the extracellular water again balance out with intracellular water. So at this point, you have diffusion neutral again. Now, this is not a normal finding. This is pseudo-normalization. And then if you let time pass by, after about second week, the cell no longer can sustain itself. It began to lyse. So you start to release the intracellular water back to the extracellular environment. So you start to lose the percentage of the intracellular water. And finally, the entire cell dies, lyse. So the whole compartment now becomes one large extracellular space. So now you have T2 shine through. So you can see by this graphic that you can find on the website, Radiology Assistant has a nice illustration of what happened with DWI signal versus ADC signal. The key point here is that for the first 10 days that you will see restricted diffusion, so it's going to be bright on DWI, dark on ADC, restricted diffusion, acute infarction. During the second week or so, you begin to see bright signal on DWI still, but ADC become normal. So here it's kind of hard to see, but it became less dark, become normal. So that's pseudo-normalization, second week. And in the chronic stage, you're going to see bright signal and bright signal. That's T2 shine through. It's roughly about 3 weeks and out. And this is a nice example from my hospital where we scan this patient every week. So during the first week, you can see patient coming with a right-sided MCA stroke, right-sided acute infarction. It's bright on DWI, dark on ADC. So you have restricted diffusion. After about 1 week, it's still bright on DWI, but notice that it's no longer dark. It's normalized. So you have pseudo-normalization. Third week, another week later, now the area becomes bright and bright. That's T2 shine through. So acute, subacute, and chronic. Restrict diffusion, pseudo-normalization, T2 shine through. Okay, so let's talk about diffusion weighted sequence and ADC or ADC map, apparent diffusion coefficient. So we know this is, by now it should be old news for you that it's bright on DWI, dark on ADC, that's acute infarction. But when you look at images, you may notice something. When you look at restricted diffusion, you look at DWI, you look at ADC. What you may notice that there are multiple set of images with DWI. There's always only one set of image for ADC, but there's multiple set of image on DWI. So you may have to scroll through, sometimes you have 3 set of images to get to the DWI image that you wanted. The CSF is going to be dark. This is the one that you want to look at, not this one, not this one. But you have to go through multiple images to get through the one you want. So why do we need multiple images for DWI? And why is there only one set of images for ADC map? So depend on your setting, some place would give you 3 set of images. Sometimes they only do 2, but minimally you need to have 2 set of images. The first one, CSF is going to be bright. That's called the B0 set of images. The one that you want to look for is B1000. The CSF is dark. So minimally, you need B0 and B1000. And you know when you're looking for acute stroke, the one that you're only interested is going to be B1000 and ADC. In this case, B1000 is bright, ADC is dark. So again, you have restricted diffusion, that's acute infarction. So what is this B0 right here? Well, if you look at the B0 right here, CSF is very bright. What does that look like to you? You should notice that that is a T2 weighted image. So it look like T2 weighted image because it is a T2 weighted image. So let's go through some of the basic physics right here. So in order to construct this B0 or T2 weighted image, remember we start with a proton that's magnetized in a longitudinal magnetization in the Z-axis. This is where the MRI magnet sits in the same orientation. You magnetize a sample of proton. The first thing you need to do is to give them a 90-degree RF pulse, flip them from the longitudinal magnetization to the transverse magnetization. And when you do that, they will start to process in the transverse plane. And you give a 180-degree RF pulse, and they would generate an echo. In this case, it's a spin echo image that would produce a T2 weighted image, such as B0 T2 weighted image. So if you see that on the RF pulse diagram, you start off with a 90-degree RF pulse, flip them into the transverse plane, and you do a refocusing 180-degree RF pulse, and that would eventually generate a signal echo. That's a spin echo image. With diffusion weighted image, we do one thing extra. What we do is this. We do another gradient. We will place 2 diffusion sensitizing gradient or 2 diffusion gradient 1 and 2. Notice that they're equal in size and magnitude. You place them one before 180-degree RF pulse. You place another one right after 180-degree RF pulse. Then you would generate a B1000. So you start off with a spin echo image. You generate B0, which is T2 weighted image, and then you come back, do exactly the same thing, except this time you added 2 additional diffusion gradient. You can call that whatever you want. We just call it diffusion 1, diffusion 2, before and after 180-degree RF pulse. So what does that do? So basically what we're trying to do is this. So we are looking at diffusion weighted sequence. What does diffusion weighted image mean? It means that we are trying to differentiate different tissue based on their diffusion property. So in other words, for example, let's say you have tissue A and tissue B, and you try to differentiate between those two. One of them has no diffusion. The other one has high diffusion. So tissue A has restricted diffusion. The water molecule doesn't move a lot. How do we differentiate that tissue from the adjacent tissue that has a higher diffusion? So that's what we're trying to do with diffusion weighted sequence. So let's take those 2 extreme examples. So tissue 1 has no diffusion, so restricted diffusion. So the water molecule does not move. So stationary proton, the water molecule doesn't move. So let's say in this group, there's 5 protons, proton 1, 2, 3, 4, 5, and they are under a strong magnetic field, like in the MRI, 1.5 Tesla. Right now, there's no gradient. So proton 1 would have exactly the same 1.5 Tesla magnetic field as proton 2, proton 3, proton 4, and proton 5. So they should experience homogeneous field. So if you look at the entire sample, together they form a very, very strong signal because everybody is in phase. You see, they all going at exactly the same frequency. They are going at exactly the same phase. So at this point, this group of proton has a very strong signal. They are in phase. Let's do the same thing. So the same group of proton, remember they are stationary. There's a lot of restricted diffusion. There's no diffusion. They do not move. So start off with the same idea as we did. Right now, everybody's in phase, so you have a strong signal. So remember, let's start off with a diffusion gradient number 1. Let's start with a positive gradient. Notice what happened here. Proton 1 is going to experience much stronger positive gradient than, say, proton 4. So at this point, proton 1 would go much faster than proton 2, then proton 3, then proton 4. And proton 5 really does not have any gradient, so it doesn't really change. So when you do that, you essentially shift their phase. So when you do that, now they are completely out of phase with each other. So you begin to see their signal loss. So together, you're going to see more signal loss because they are out of phase. They are no longer in phase. So that's not good. So what can we do? Well, we can do it again, except this time we're going to do in the opposite polarity. So instead of a positive gradient, now I'm going to give them a negative gradient. So diffusion gradient number 2, negative gradient. What does that do? Well, for proton 1, now it's going to experience the strongest negative gradient compared to proton 2, 3, 4. So proton 1 will become slower than proton 2. Proton 2 will be slower than proton 3, and proton 3 will be slower than proton 4. So in essence, you'll shift them back to their original position. So when you do that again, they are in phase again. So together, they present with a very strong signal, as if nothing has happened after you do the 2 diffusion gradient. So how does that compare to a stationary proton, the proton with no restricted diffusion, versus a proton that has high diffusion, the proton that's moving around? So let's take this 2 groups. Again, the bottom group right here, group A, that's the one that has restricted diffusion or stationary proton. The top group right here, those one that is not stationary, they will move around. So initially they are in phase, everything's fine. So both of them has a very strong signal. So we start off with the diffusion gradient number 1. All of them is going to experience same type of shift because they are experiencing the same positive gradient strength. So you're shifting out of position. Now, before you give them the second gradient, diffusion gradient number 2, what happens if the top group, they start to move? So remember, the bottom group is stationary. They do not change position. But the bottom one, the top one here, they are not stationary. They have high diffusion. So they start to diffuse in different places. Those start to change their position. Now, if you give a second diffusion gradient, negative diffusion gradient, for the stationary proton, you'll basically shift them back to their original position. But the same thing does not happen with the one with high diffusion. So you shift the stationary. So if you have a restricted diffusion, they will be shifted back to its original position. On the top one is a different story. So after you give the diffusion gradient 1 and 2, now you can separate them The bottom one is going to have a strong signal. The top one is going to have more signal loss. So that's how you can differentiate between a group of proton that has restricted diffusion versus group of proton that has high diffusion or higher diffusion. So the key point here is that if you have a high diffusion, you're going to experience more out of phase after those two diffusion gradients. So you're going to experience more signal loss. On the other hand, if you have a low diffusion, so restricted diffusion, you're going to experience less signal loss, so stronger signal. And also notice that the strength of the gradient is also going to affect the signal intensity. So if you have a stronger signal intensity, you're going to experience more out of phase. So in other words, the stronger the gradient, you will induce more signal loss. So that's kind of the take-home point. The key point is that if you have a strong gradient, diffusion gradient, or if you have a high diffusion, you will experience more signal loss after those two diffusion gradient. So again, graphic representation, 90 degree, 180 degree. For diffusion gradient, we do a gradient number 1, diffusion gradient number 1. After 180 degree, you do diffusion gradient number 2. And don't worry about this complex equation. Just notice that the signal intensity is proportional to this thing called B factor or B value. The B value just simply calculated by, again, don't worry about the equation. I just want to show you what's composed of the B value. So the B value is dependent on how strong the diffusion gradient is, how long do you apply that diffusion gradient, and how long do you wait between diffusion gradient 1 and diffusion gradient 2. Bigger the number it is, the bigger the B value. So another way to put it is that the higher the B value, the stronger signal loss you experience after those two diffusion gradients. I hope that makes some sense here. So basically, when you look at the B0, the first set of image, the B0 image, that's just diffusion weighted sequence before you give those diffusion gradient. So without the diffusion gradient. B1000 is after you give them a strong diffusion gradient. You can do B2000 if you like, or B500, but clinically, we think B1000 is strong enough to differentiate most of the pathology. So when you look at B0 and B1000, and you can see that you start with a B0, and if you look at the area, this is area of acute infarction, as you can see. So this area has restricted diffusion, or a proton that does not move, stationary proton. So compare that, for example, to CSF. In CSF, there's no restriction. So the diffusion water molecule inside the ventricle, they can diffuse very freely, so they have a high diffusion. Compare that to brain tissue, the diffusion is lower compared to CSF. And of course, in the area of infarction, you have diffusion that's very low. So you have an area of restricted diffusion. So as we mentioned earlier, after you give a strong B1000 value, the area that's going to experience the most amount of signal loss is going to be the one with high diffusion. So CSF is going to experience a lot of signal loss. Therefore, it comes from a bright signal to a very dark signal. Brain tissue is somewhere in between. The area with restricted diffusion, with no movement of the water molecule or little movement of water molecule, is going to experience the least amount of signal drop. So if you look at before B1000 is bright signal, after B1000, it still is bright signal. So the amount of signal drop is low. That's why restricted diffusion looks so bright on DWI compared to, say, water molecule in the CSF. So that's sort of the concept of B0 with diffusion weighted sequence. But we have a problem. Okay, so this is a problem. Let me show you a case to illustrate the point about the problem here. Okay, so this case is somebody who just had a heart transplant, now presented with a vision loss and seizure. And if you see multiple images like this, you have flare sequences, right? Something looks very abnormal here, bilateral, kind of symmetric, along the posterior aspect right here. And you look at diffusion, it's bright. DWI is bright. And this is a post-contrast. You can see there's no contrast enhancement. So based on this set of images right here, what do you think is the most likely or the likely diagnosis? What would be in your differential diagnosis? Is it ADEM, acute disseminated encephalomyelitis? Is it PRES, posterior reversible encephalopathy syndrome? Maybe it's a watershed acute infarction, or is this a prolonged seizure? What does everyone think as far as the likely diagnosis here, based on this set of images? So good. So I see a couple of response. Good. So let me show you the response that we get. I apologize, the letter is a little bit small, but we have 3 equally likely choices, right? Some people, some pick PRES, some pick watershed infarction, some pick prolonged seizure. So the answer is you're all correct. You could be any of the 3, right? But what if I show you these images right here? I know that you don't have a choice. Just thinking to yourself, if I show you ADC, does that change your mind? Does that change your mind about what this is? Remember, the patient's symptom is acute, right? So after you look at ADC, it's bright on DWI, that's true. But look at the ADC, it's also bright. So there's actually no restricted diffusion. This is T2 shine through. So it turns out this is PRES, right? This is not acute infarction anymore because there's no restricted diffusion, even though the location is very good for watershed infarction, but it's not bright and dark. So this is not acute infarction anymore. So this is PRES. And for those of you who know, I think most of you know about PRES, it involves a posterior circulation more commonly than anterior circulation, but sometimes they can present like this watershed distribution. It has to do with acute hypertension, and the acute hypertension is overwhelming the autoregulation of the vasculature. So therefore you have vasogenic edema. So a lot of signal here you see bright signal are not cytotoxic edema, not restricted diffusion, but vasogenic edema. So, and the most common cause, of course, is acute hypertension. But remember, there are drugs that can cause that. So in this case, it's caused by immunosuppression drugs. So T2 shine through. So what's the problem here? Well, the problem in this case is if you just look at DWI, both case, here you have a PRES, here you have DWI. Both case DWI, excuse me, this one has acute infarction. Both case DWI shows a very bright signal. So how can we tell the bright signal is due to A, diffusion restriction, B, T2 shine through or intrinsic T2 hyperintensity, or maybe it's from both? The answer is that actually we cannot just look at DWI. So that's a problem, isn't it? So if you cannot tell one is infarction versus one is not infarction or acute infarction, so how good is DWI? So that's a problem. So what's the solution? Well, the solution is this. We have a B0 and we do a same set of image in the same position. We give the diffusion gradient after you do B0. So what if we take one voxel, for example, the voxel in the ventricle, CSF? If you compare the signal intensity between B0 and B1000, if you look at B0, it's very bright. So because it has a bright signal, I'm going to assign that a high value. After B1000, it's very dark. So the signal intensity low, I'm going to assign that to a low value. The differences between those two values is a big number. And that's your calculated ADC value. On the scale of ADC value, if I have a high value, I'm going to assign that to a much brighter color. So in this case, almost white color. And I'm going to take that and map it into exactly the same location as those two voxels. On the other hand, let's look at the area with restricted diffusion. At B0, you have a high signal to start with. Remember, acute infarction is bright on T2. Sometimes vasojagging edema, cytotoxic edema combination. After B1000, of course, it's still going to be very bright. So we're going to high value, high value. The difference is going to be a small number, small value. So small ADC value, I'm going to assign that small number into a lower scale, darker scale. I'm going to map that to the same location with this two voxel. Now you have a map. And you can do the same thing on every single voxel. Compare B0 to B1000, you map them to the same location, you calculate the ADC value, and you map them into the identical location, and therefore you come up with an entire map. So that's your ADC map. So the problem solved. So another way to look at it is that you have a B0, which is just a T2 weighted image. You have B1000, that's a T2 weighted image with diffusion information. And what if we can subtract T2 value from these two images right here? You can make that into an ADC map. In fact, you can actually calculate the ADC value, right? Normally, you can do that on your PAC station. It's a rough calculation, but you can do it. CSF, I always use CSF as my internal reference. It's roughly 3,000. So the problem is now solved, is that because we cannot tell whether or not this is restricted diffusion of T2 shine through on DWI, all we have to do is look at our reconstructed ADC map. If you have a low ADC value, dark signal, that's restricted diffusion. So bright, dark, low ADC value, acute infarction. If it's bright and bright, that has a high ADC value, that's T2 shine through, not restricted diffusion. Okay, so hopefully that's not too confusing. But what about this case? You have a 34-year-old female comes in with overdose, a drug overdose. The clinicians, the patients in ICU, they want to make sure that patient does not have acute infarction. What do you think is the diagnosis based on this picture right here? Right now, I don't have the code yet, but just think to yourself, what would you choose as a correct answer? You have T2 weighted image, you have flare, you have DWI. Do you see an area of acute infarction? So maybe there's nothing acute, or maybe there's diffuse hypoxic ischemic injury. Maybe you see bilateral basal ganglia acute infarction. Perhaps this is another case of PRES, or maybe there's subacute infarction, not acute infarction. Right. So look at those three images and think to yourself, which one would you pick? Now we know that the take-home message is that you never look at DWI without look at ADC map. So what if you see that? If I give you ADC map, what would you pick as your correct answer? So after the ADC map, are you able to tell, or did you change your mind? Sip of water and then see if you can come up with that. It's a little bit tricky. Some of the cases a little bit tricky here. Okay, so if you look at the response, majority of you pick the second answer, hypoxic ischemic injury, but there's also a good number pick bilateral basal ganglia infarction. Very nice. So the correct answer is diffuse hypoxic agnostic injury. So if you look at the DWI right here, so this is a dangerous of looking at just DWI. And here I'm giving you another patient with same age of a normal finding for reference. Notice that because the lesion is diffuse and bilateral, it's very, very difficult to pick up, right? In fact, I believe this case initially was called negative, nothing acute. I believe the person who read it did not look at the ADC map. If you look at the normal ADC map, a normal ADC map should look relatively, the gray and white differentiation is not going to be great. So you cannot really tell gray matter from white matter all that well. This one, whenever you can see on ADC map, the gray matter and white matter become too well differentiated, be careful. So the point here is that do not skip ADC map, even DWI look normal, right? Because sometimes you maybe think that, well, if DWI looks normal, I don't need to look at ADC map because that doesn't tell me more. I only look at ADC map if I see an abnormal bright signal. In this case, what if the entire brain has abnormal bright signal? Then you may be fooled that the patient does not have anything wrong. This ADC map will help you because notice that a normal ADC map, the differentiation is not great. Why is gray white matter differentiation not great for ADC map? Because this is a calculated map. So if you look at the value between the white matter and the gray matter, you can see that they are overlapping values. Sometimes their value is very similar. So when the computer assigns the color scale, they may assign similar color scale. So therefore, gray white matter differentiation on ADC should not be that well defined. On the other hand, on DWI, you see that the gray matter and white matter, there's a nice differentiation. Why? Because remember, DWI has a T2 property inside. So you're looking at the differentiation between the T2 value between gray matter and the white matter. So just don't skip your ADC map. It's a trap. Okay, let's switch gear to, so now we can see how useful the next 10, 15 minutes. Let's go through some cases that's other than acute stroke. So some other usefulness that we can use for diffusion weighted sequence. For example, this case, you have a 37-year-old person comes in with a headache. What do you think is the most likely diagnosis? Is it A, metastasis? You can see that on diffusion weighted sequence, ADC, it's bright on DWI, dark on ADC. You have a post-contrast sequences shows a rim enhancing lesion with surrounding T2 hyperintensity, so surrounding edema. So what do you think is the most likely diagnosis here? Is this a metastasis? Is this abscess? Is this a GBM? Maybe this is a multiple sclerosis, or E, this is embolic infarction. So rim enhancing lesion. Okay, so most of you, good job. Pick this as an abscess. So the correct answer is abscess. Very good. So sometimes you can come up with a mnemonic of a differential diagnosis for rim enhancing lesion. I don't like a mnemonic that's so long. That basically just means that anything can look like this. But I think the most important thing that we should be worried about is metastasis versus abscess versus GBM or high-grade glioma. So let's say I'll show you 3 different cases. One patient has metastasis, the other patient has abscess, the third patient has a GBM. The question is that, are we able to differentiate between all 3 of them based on just T1 post-contrast, right? All 3 of them shows rim enhancement, but which one's metastasis, which one's abscess, which one's GBM? Maybe you can tell, maybe you cannot. What about T2 weighted image? Does that help? Well, all 3 of them, unfortunately, will give you lots of edema. So that doesn't seem to help. There's some other feature that may help a little bit. But what's the most useful, for example, the differentiate between abscess from other two is diffusion weighted sequence. So this one right here, you can see there's a lots of central restricted diffusion. That's abscess. And this one's GBM. This one's metastasis. So the pattern for restricted diffusion, that's different than those two. For abscess, the restricted diffusion is more central, right inside the area that's central necrosis or the area that's full of pus. For GBM, the restricted diffusion is along the periphery where the enhancement is, not centrally. So that's one great way to tell the difference between abscess and, say, GBM. There are some other things, as I mentioned, on other sequences that can be also helpful for differentiation of abscess. For example, a T2 hypointense rim. And if you see they are next to a ventricle, sometimes they were extending into the ventricle, cause ventriculitis. In this case, you can actually see pus in the other side, in the other lateral ventricle right here. Satellite lesion, and the satellite lesion tend to point toward the ventricle. That's another clue for abscess. And remember, the abscess has a very smooth inner margin. So inside the inner margin is smooth, unlike GBM, it tend to be very ugly and irregular enhancement. And then sometimes we talk about this double rim sign or dual rim sign. On T2 or SWI, you can see this dark signal outside, bright signal inside. So that's a double rim sign. So those are the ways. So using diffusion weighted sequence, one of the lesions will show restricted diffusion is abscess, central abscess. Good. So let's look at another case here. 67-year-old female with seizure. You have multiple images right here. T1 flare, T1 post contrast, diffusion weighted sequence, DWI ADC. Now I think you can see there's a lesion. There's abnormal signal right here, abnormal enhancement across the corpus callosum. You can see that it's bright on DWI, dark on ADC. So you know there's a restricted diffusion. So what other lesion can show restricted diffusion besides the lesion that we have already talked about? So is it A, acute infarction, B, another abscess I'm showing you, C, high-grade glioma, D, multiple sclerosis, or E, a CNS lymphoma? What do you think is the most likely answer? I hope everyone has strong coffee this morning. I know it's early in Thailand, so thanks for staying awake. Okay, good. So I don't know if you can see the result right here. So half of you pick high-grade glioma, almost half pick CNS lymphoma. So very good. So the answer here is actually high-grade glioma, but lymphoma is in the differential diagnosis for sure. But why do we pick high-grade glioma over lymphoma? So first of all, let's talk about restricted diffusion that's associated with high-grade tumor. So why does high-grade tumor, so more specifically hypercellular tumor, higher density, cell density, cause restricted diffusion? And that again has to do with a percentage of intracellular water. So for example, this is a normal tissue, right? You have intracellular water that's more restricted compared to extracellular water that does not have restricted diffusion. If you compare this normal tissue right here with a tissue that's hypercellular, like a high-grade tumor, hypercellular GBM, lymphoma, for example, it would naturally show more restricted diffusion compared to the normal tissue. So that's a reason why hypercellular tumor has restricted diffusion. So in this case, this is a GBM. Notice that there's flare signal that shows a lot more infiltrative margin involving other area that does not have enhancement. So for lymphoma, they tend to show more enhancement. So the better answer here is going to be GBM. And for if you come up with differential diagnosis, if you think about mass lesion that crosses corpus callosum, the three things I think about right away always is lymphoma, is GBM, is tumor-factive MS. So MS is something to think about, tumor-factive MS, multiple sclerosis. This is just an example of what a GBM would look like. GBM, remember, is much more thick rim enhancement. MS lesion tend to show this advanced border incomplete enhancement, and lymphoma in an immunocompetent patient tend to show this very homogeneous enhancement. But whenever I see a mass lesion that crosses corpus callosum, I think about lymphoma, I think about tumor-factive MS, multiple sclerosis, or I think about CNS lymphoma. What about another type of tumor? Right, patient comes in with confusion. What about this case right here? What is the most likely diagnosis? So you can clearly see there are multiple lesions. So T2 weighted image, T1 post contrast, diffusion ADC, again, bright on diffusion, dark on ADC. So you have multiple lesions with restricted diffusion. So what do you think about this case? What's the more likely choice? Is it acute infarction? Is this abscess? Is this another case of GBM? Is this CNS lymphoma? Or is this metastasis? And then when you pick the answer, you have to think to yourself, why do you pick the answer as your best answer? You need to be able to justify your finding. So good, we're getting a nice response here. So when you look at the response here, I think half of you pick, slightly majority pick lymphoma, but also quite a few pick metastasis. So let's talk about that a little bit. So the answer here is CNS lymphoma. The reason why CNS lymphoma in this case is better than metastasis, of course, you should think about metastasis because you see multiple enhancing lesion. Whenever you have multiple enhancing lesion, you definitely should think about metastasis also. But the thing is that most of the time with metastasis and also with GBM or abscess, they are going to present with a REM enhancing lesion. So notice how big these two lesions are, how homogeneous and enhancing they are. It's very strange to have a high-grade glioma, high-grade tumor, GBM, or metastasis to be this big without any type of central necrosis. So it's unusual to have a metastasis with solid enhancement like this, rather than REM enhancement. So that's a reason why I think lymphoma is a better answer here. And again, when we talk about lymphoma, just like other high-grade tumor, the reason why there's restricted diffusion, number one is because they are also hypercellular. Hypercellular tumor has restricted diffusion. On top of that, though, they also has high NC ratio. Notice how big the nucleus compared to the cytoplasm. So we can imagine the water molecule in here are much more restricted compared to other type of cell type. So lymphoma, in addition to hypercellularity, also because they have a high NC ratio that causes restricted diffusion. They have more restricted diffusion compared to GBM. That's true with any type of cell that's small, round, blue cell tumor. And this is an old paper talk about lymphoma versus a high-grade glioma. You can see that their ADC value for lymphoma is on average lower than high-grade glioma. So that's a reason why if you calculate ADC value, if it's much lower, think about other type of high-grade tumor, such as the small blue round cell tumor, the ones that end with blastoma, lymphoma, or one end with blastoma like medulloblastoma, neuroblastoma, retinoblastoma. And for some of the classic finding for CNS lymphoma for immunocompetent patient is that they tend to be supratentorial. And also notice again, the pattern of enhancement is very homogeneous, very solid, without central necrosis before treatment. And that is very good for CNS lymphoma. And also they tend to cross corpus callosum. Remember the 3 lesions that crosses corpus callosum: lymphoma, GBM, tumor effective MS. And if I see a solid enhancement like this is lymphoma. Another thing, they tend to prefer central structure, central gray, along the ventricular, periventricular region, ependymal region. So put all this together, those are a good example for CNS lymphoma. Okay, let's talk about a few more lesions, then we're going to wrap up for this presentation. What about this case? You have a younger patient, 31-year-old female, comes in present with hearing loss. What do you think is the most likely diagnosis based on these images right here? You have, again, diffusion weighted sequence. You can clearly see something that's very bright on DWI, dark on ADC. On FLAIR, it looks heterogeneous. On T2, it looks very bright, like CSF. There's no contrast enhancement. And thinking to yourself, is this an extracellular tumor, or excuse me, extraaxial or intraaxial tumor or mass? So what do you think? Is this metastasis? Oh, excuse me, meningioma? Is this abscess? Is this arachnoid cyst? Is this epidermoid cyst? Or could this be a schwannoma? So I cannot fool anybody here. So everybody pick epidermoid cyst. Very nice. This is epidermoid cyst. This is a extraaxial tumor right by the CPA, so cerebellopontine angle mass. Lots of restricted diffusion. So this is another pathology that has a lot of restricted diffusion. So remember that in your differential diagnosis for restricted diffusion. Now, as you know, that is a ectodermal inclusion cyst. It's very similar to dermoid, except dermoid has other skin component to it. This is a scary lesion in terms of on CT, because on CT, they can look like CSF. And if you give contrast on CT, you also does not enhance. So the temptation that you pick this as a arachnoid cyst, but definitely look at diffusion. This does not look like CSF. And also on FLAIR, because it's not CSF, they tend to be much brighter or dirty. So this is a classic picture for epidermoid cyst, restricted diffusion. And when I think about CPA mass, I think about vestibular schwannoma as my top choice, meningioma is my distal second, and epidermoid is distal third. But remember, vestibular schwannoma, meningioma, they tend to enhance very avidly. So right away, you know that this is not schwannoma or this is not meningioma. And this is epidermoid because of strong restricted diffusion. And what about this case right here? 52-year-old female, headache for a few days with seizure. And this is one of the lesions that the residents and everybody here need to be able to recognize what they are. Here you have a diffusion weighted sequence again. You can see lots of restricted diffusion involving a fairly classic location, medial temporal lobe, and also on the lateral part of the temporal lobe is bilateral but asymmetric. You can see there's signal flare, there's some cerebral edema. T2 is bright, and there's some swelling of the brain parenchyma. So what do you think is the most likely diagnosis in this case? When you give contrast, sometimes it enhances, sometimes it does not. So contrast does not help you as much. So is this mesiotemporal sclerosis because the patient presented with seizure? Is this herpes encephalitis? Is this arterial infarction because of restricted diffusion, or maybe this is venous infarction? Right. What about, is this another epidermoid cyst? Right. Is the involvement extracellular, extraaxial or intraaxial? Look like everybody picked herpes. That's very nicely done. This is herpes encephalitis in a very classic location. This is something that we all need to recognize, because sometimes they can present just unilaterally, and you see a case that has been mistakenly called as acute infarction. The reason why we need to recognize this is that if you don't treat this patient early, you're going to have a much, much higher morbidity and mortality. So in the United States, a lot of times if we suspect herpes, before the diagnosis is made, they would treat the patient empirically. They would just give the patient antiviral treatment. And then if the CSF comes back negative, they will stop the treatment. So that's a key. Early treatment is a key for herpes encephalitis. So if you suspect herpes, you have to mention it so they can treat the patient in time. For adult and in older kids, HSV type 1 is the most common type. Again, the classic location is going to be involvement of the limbic system. So medial temporal lobe, amygdala, insular cortex, hippocampus, all those are the very typical location. And they commonly spare basal ganglia. So unlike infarction, for example, they tend to spare basal ganglia, so that's something to remember. And that's different than the neonatal herpes encephalitis. The neonatal one tend to occur with HSV type 2, and those are the transmitted during birth. So the mother is infected with herpes, and during the birth, through the birth canal, the patient also got infected. The pattern is not classically involving the medial temporal lobe, but rather involving diffusely, a lot of time involving the cortex and the deep white matter. So I think I have two more cases. So they're just about time to just hang there. We're almost done. We have a 58-year-old male with encephalitis amid of alcohol withdrawal. What's the most likely diagnosis? This is a pattern recognition type of picture here. You have diffusion weighted sequence. You can see within the PON, you have a Brian DWI dark-on ADC, Brian flare, Brian T2, usually does not have does not have enhancement. Notice that there's sparing of a structure centrally. So what do you think is the most likely diagnosis? And this is one of those cases that if you've seen one before, it becomes a pattern recognition that you probably not miss this. Okay, let me show you the results. So lots of you pick the first answer, osmotic demyelination syndrome. Quite a few, some pick acute infarction and also possibly Ponting glioma. So let's look at this. And the answer is osmotic demyelination syndrome. Used to call, or is also known as central Ponting myelinosis. The reason why we prefer to call this osmotic demyelination syndrome is that you may not involve Ponting only. You can have extra Ponting involvement. Most of you remember from medical school or study medicine that the major cause of this is rapid correction of a hyponatremia, or patient comes in with low sodium, you correct the sodium level too rapidly, that can cause patient this finding. So the risk factors is basically anybody who has a risk of electrolyte imbalance. So even if you correct it slowly, sometimes the patient can still develop osmotic demyelination symptoms. So it doesn't have to be always rapid correction of sodium, but that's a classic scenario. So any scenario such as prolonged vomiting, patient just have a transplant, anything that can cause electrolyte imbalance has an increased risk for osmotic demyelination syndrome. And is the reason why, again, it's called osmotic demyelination syndrome rather than central pontine myelinosis. It's also commonly, it can also affect extra pontine structure, such as thalami, such as basal ganglia, and subcortical white matter. The classic finding that you will see is sparing is a diffuse involvement in central pontine, and also sparing of the periphery and the cortical spinal tract. And it does show restricted diffusion, usually does not have enhancement. And some people come up with a very cute sign called piglet sign. I guess it does look kind of like piglet, right? The eyes, the snout, the nose, and the mouth. The piglet sign. Okay, one last case. This is not a very common type of scenario, but we do see that especially if you work at a large children's hospital. This is something to think about, to remember. This is a patient comes in with acute lymphocytic leukemia. Patient is under treatment in the hospital and suddenly overnight develop what looked like acute infarction. Speech is funny, patient become imbalanced when she's walking. And this is what you see was flare, post-contrast, DWI, again, is bright. And look at the ADC, it's a little bit dark. It's a little bit asymmetric, it's also dark on the right side. What do you think is the most likely diagnosis in this case? So is this maybe a CNS involvement of her leukemia? Is this a PML, progressive multifocal leukoencephalopathy? Is this watershed infarction? Because you do see restricted diffusion and patient has a stroke-like symptom. Do you think this is due to some type of medication? And if so, what type of medication? And maybe this is a venous infarction, because it's not in a very typical arterial territory. So what do you think this might be? Again, this is some of the very recognized phenomenon, especially in kids under certain condition. So you may see this, it doesn't have to be in kids, but it happens more common in kids. It can also happen in adults. But so if you work in a larger setting, that you may come across this finding. All right, so look at the red here. Majority of you do pick drug toxicity. So medication effect, very good. The question is what type of medication? So this is a phenomenon that we can see with intrathecal methotrexate. It does not have to be intrathecal, but that's what we most commonly seen, usually with high-dose methotrexate. And it typically occurs anywhere between few days and up to about 2 weeks after the treatment of methotrexate. So patient comes in with acute leukemia. One of the standard treatment is going to be intrathecal injection of chemo, methotrexate, and patient may develop this. And so this is something that's very good to recognize. Notice that it's very strange to have some type of acute infarction involving the only white matter or central sentinel valley, does not have involvement of the cortex. That is very strange for acute infarction. So just remember this entity. And predominantly involved, it could be, the funny thing about this is that it could be bilateral, you could be unilateral, sometimes they can change size. So just remember that if it doesn't make sense, think about what kind of medication the patient is on. Diffusion-weighted sequence is very, very sensitive to pick up the early case of neurotoxicity for methotrexate. And sometimes if you withdraw the medication, patient can recover completely. In this case, the patient does develop a permanent gliosis. But of course, the restricted diffusion is resolved 10 months later after the medication is stopped. This is another case that we have, same thing, methotrexate. Patient has about 3 days of treatment. Notice that this one's much more subtle. There's actually nothing on flare and T2. You can barely see signal within diffusion and ADC, dark signal, a little bit dark signal. So this patient also has intrathecal methotrexate toxicity, and the medication stop, patient also recover completely. So just be aware of the finding. So the whole point about this lecture is that just to show you that, yes, diffusion-weighted sequence is very important for stroke imaging, but you can take beyond that. There's a lot of different entity, and you can find table like this on internet anywhere. I find the source here I got is from MRI questions, but you can find on different multiple websites. So just remember, whenever you see lesion with restricted diffusion, there's a certain signal characteristic that can help with your differential diagnosis. That is all for today's lecture. Thank you so much for staying awake. I know it's a long lecture, it's early in the morning, so thank you very much. If you have any question, please feel free to email me. And I just want to let you know that I have a little YouTube channel that I put some MRI physics stuff. If you search YouTube under the keyword neuroradish, you will find a few lectures. If you're interested in basic MRI lecture, MRI physics, I have a lecture upload on this channel right here. So thank you.
Thank you so much, Dr. Wu. This is a fantastic lecture that you put everything together from the basic to advanced. And I'm glad that you showed the last case that at 16 years old to fit in the theme of the pediatric neuroimaging.
Yes.
And I just know that you are a YouTuber. Wow, you have your own channel. That is good.
There's only I think only 4 videos in there, so don't expect too much.
No, but I mean after today's lecture, you're gonna have more subscribers. People gonna look on that YouTube because yeah, that is a good thing because not that many people give a talk on the MR physics and simplify that stuff.
So yes. So yeah, it's a topic that we all need to learn, but it's very, honestly, it's very boring. So as a resident to learn MRI physics, I always find very, very boring and very difficult. So I'm trying to put that in more clinical context. Hopefully that will be easier to learn or less painful to learn.
Yes, I do agree. So thank you so much for giving a talk and simplify the difficult topic and make us understand about the importance of the DWI that we can use it for next lecture. Because next week lecture is going to be about the tumor imaging in children.
Perfect.
Right, this is really perfect. Yeah.
Right. So remember, diffusion-weighted sequence is also very, very important for tumor imaging. Hypercellular tumor will have restricted diffusion. Usually, not always, but usually that means higher grade tumor. So hypocellular tumor, the low grade tumor, they tend to have, not only they do not have restricted diffusion, often they have increased diffusion compared to the adjacent tissue. So that's kind of a very important point for diffusion-weighted sequence and tumor imaging.
So I have a couple questions because there are many techniques about the diffusion-weighted images.
Yes.
Like sometimes we talk about a DWI EPI, which is a fast DWI, or sometimes we're talking about the vendor-specific technique, the resolved technique.
Yes.
Or even sometimes for a cholesteatoma that we have the coronal haste DWI. Can you explain about those techniques and what is the difference on those things?
So diffusion-weighted sequence is just like, as earlier I was saying that sometimes, we try to differentiate between different tissues, tissue A and tissue B, based on their different property, right? The reason why we can tell a gray matter from white matter on T2 weighted image is because their T2 property is different. So they have different signal intensity. So if you use T2 weighted image, try to differentiate, for example, CSF versus a tissue, CSF is going to be much brighter because they have a very different T2 time. So we can do the same thing with diffusion property. So if you have an area with restricted diffusion, has restricted diffusion like acute infarction, next to adjacent normal tissue that does not have restricted diffusion, you can try to use that property to highlight the differences. So you try to make one brighter than the other one. So diffusion weighted image is just a way to do that, to show different property. But there are different ways you can make a diffusion weighted sequence. Just like, for example, T2 weighted image, you can do that with span echo. You can do that with gradient echo. So there are different techniques, but they'll try to do the same thing, T2 weighted image. So for diffusion weighted image, you can do many different ways. The most common way by far is use this method called EPI, echoplanar imaging. Echoplanar imaging is this thing we call single shot. So what that means is that it's very, very fast. So you can do the entire set of image usually under a minute. Compare that to other sequence like T2 weighted standard fast span echo T2 weighted image may take more than a few minutes, 5 minutes, 3 minutes to finish the image. The reason why you want to use EPI, the fastest image technique that we have, is that you try to detect those microscopic motion, right? The diffusion of the water molecule is very microscopic. You don't want to let other bigger motion like respiration, cardiac motion. If you have too much large motion, that's going to obscure the micro motion. So you need some sequence that's really fast to essentially freeze those larger motion. So most commonly, by far, all the diffusion weighted sequence that we use for stroke, I'll typically do with EPI. So when we say diffusion weighted sequence, normally we mean EPI diffusion, echoplanar imaging. But the problem with EPI is this. The advantage of EPI is that you can do it very, very, very fast. But actually, let me see. I might have, can you still see my screen?
Yes. Uh-huh.
Okay. So let me show you another case that I didn't have time to put in here. That's answer your question perfectly right here, is that you have a case here with cluster teratoma in the middle ear right here. So with cluster teratoma, that's another pathology that shows restricted diffusion in this very young patient right here. So, but the problem is on CT, you don't really know if this is cluster teratoma or maybe this is just scar tissue, granulation tissue. Sometimes hard to tell just on CT. So cluster teratoma shows restricted diffusion. If you look at this two type of diffusion weighted sequence, with EPI, the problem with the EPI is that it's a very fast sequence. It's great for the brain, but anywhere that has susceptibility artifacts, such as air, that shows a lot of susceptibility artifact, you're going to have problem with EPI. So it's not good for the area. If you have area that's right next to a bone, especially right next to sinus or air, EPI is not going to work too well. So we need to find another method that is less vulnerable to susceptibility artifact. So that's where other type of quote unquote non-EPI diffusion comes in. This case is a haze diffusion. It's sort of a span echo, very fast span echo type. You can see that the amount of, same amount of tissue here. You see how big the pathology is that occupy the whole middle ear cavity here. But we can barely see it on EPI. But with a non-EPI diffusion, you can see the lesion much better. So that's one way of try to get rid of the negative or the side effect of EPI diffusion. So the head and neck imager they love haze diffusion for that reason, because there's so much air in the middle ear cavity and mastoid air cells. If you use a standard EPI diffusion, you're not going to see a lesion very well, just like in this case. So you need another type of sequences to make a diffusion weighted sequence. So we choose haze diffusion. Does that kind of answer part of the questions?
Yeah. So most of the time for the brain, we do like the EPI technique.
Right.
But if we want to do, go ahead.
So right. So when you look at the brain imaging, so when you look at the diffusion weighted sequence on your brain imaging, it's almost always EPI.
Yeah.
The different technique of EPI. So the classic EPI is you do a image and you do fill in the K-space. You fill in very, very fast. So they call single shot. So you take it from one end, go all the way right in the filling entire image in one shot. So it goes very, very fast without any break in between. The newer technique, such as resolved, for example, is another EPI technique, but they break the image into multiple sections. So it's like multi-segment the EPI. So the disadvantage, of course, is take longer to do, but the advantage that you can have a better spatial resolution. And also you have a less problem with susceptibility artifact. So if you compare your classic EPI diffusion versus a newer multi-segmented EPI like Resolve, you will find that Resolve have a better spatial resolution and also has a less problem with susceptibility artifact.
So which means like if we want to do like the DWI on some area that have a bone and air interface, we may need to choose to do like a resolve, which is like a vendor specific sequence or like a haste DWI technique.
Right. So resolve and haste is different sequence, but you're right. You need to find a way to get rid of the susceptibility artifact. So I think resolve is a good compromise. And I think at Riley we do mostly a resolve DWI. So the images, you can see the spatial resolution is better, and then the susceptibility artifact is less a problem. It takes a little bit longer to do, but it's still pretty fast.
I see.
Right. So that's a great question.
Yeah. So one thing that because like for me, when I see any mask in the head and neck or any like in the body part, I would recommend I always teach and tell my resident and fellow to get DWI. At least you get some idea on that mat. Is that like a high grade tumor or low grade tumor? But one question that we usually get is like what is the B value that we should do? Do you have any like a cutoff B value? Because for myself, I normally say, yeah, let's do like a B1000.
Yeah, so B1000 is basically a standard. That's the standard one that we use. And it's there's no reason that you cannot pick a higher B0 or higher B value. In theory, that the higher the B value goes, you become more sensitive to diffusion. But the problem was if you go in the B value too high, you're going to lose. Remember, each additional diffusion weighted sequence, a diffusion gradient that you apply, you're going to lose more signal. So eventually, if you use too high of B value, you're going to lose signal of all tissues. The image is not going to be all that great. It's just going to be too much signal loss. So you may not find, you have to find the ultimate balance. So that's why some children's hospital, they will actually, instead of using B1000 for neonates, they will actually use lower B value, like B800 for acute infarction, HIE, and stuff like that. The reason is that the neonatal brain is just so much more watery. There's just much higher watery content. So the adult B1000 may not apply as much, but I don't think the difference is that much. I think Riley will still use B1000.
Yes. Okay. So that's what I think. So which means like besides like the image quality and resolution for the higher B value is probably not that good, but it's also take longer time.
It's if you just do, instead of say B1000, you say skip B1000, let's do B2000, then you're not really adding more time. But if you say let's do B0, B1000, and B2000, of course that additional B2000 would add extra time. But diffusion weighted sequence is so fast anyway, so you're not adding too much time. But it just depend on, does that give you more? I remember kind of looking at the paper. I think some of you may or may not be familiar with transient global amnesia, where you're looking for a very, very small dot of diffusion weighted sequence. There are papers that talk about if you increase your B value, you may be able to detect, or even if you're looking for more, let's say you have a patient comes in with embolic infarction, you see 1 or 2, and that may not explain patient's symptom. It's like, that's strange. Just one little embolic infarction can cause that severe symptom. There are some people suggest that if you increase B value to maybe B 1500 or 2000, you may be to pick up even more lesion. But at some point that we decide that B1000 is good enough for most of the clinical application. But there's no reason why you cannot go any higher or lower. It's just that it's all depend on whether or not what you're used to.
I see.
Like if you're not used to look at B800, then you may not pick up the lesion that just because you may not know what you're looking at because you're not using to look at it. So basically B1000 is our standard clinical
neuro
value.
because like I know that body people sometimes they do just like a B500 and 800.
They do, right?
But for neuro,
right, because the property, that's difference between brain and body, right? Different organ, they may have a different, because the slope of ADC is not that we take B0, B1000, we use that as a straight line. So we are essentially assume that it's a linear ADC function, if you will, it's a linear. In reality, it's actually not. It's an exponential. It's a curve. So if you want to have a very, very accurate ADC coefficient, you need to measure at multiple points. So you have to start as B5, B10, B15, B20. And if you do that, it's no longer a linear curve. But if you do that, it takes forever. So that's why it's not practical clinically. So most of the places that would do just B0, B1000. Sometimes you will see B0, B500, and B1000. But usually that's about it.
I see, yeah. And right now at Riley, we trying to do more like a diffusion weighted images on the spine imaging. Do you have any comments on that part?
I think our result is getting better and better. I think it's just a matter of just keep refining technique. The reason why spine imaging is much more difficult to do compared to brain imaging for DWI is remember when you look at spine, it's such a small space surrounded by bone. So there's a lot of susceptibility problem to start with. So by trying to do that, and the signal noise ratio is not great to start with, so it's much, much more difficult to try to do that compared to brain, where you have a lot of tissue with a bone that's very, very periphery. So spine is usually very difficult. So it takes a lot of trying different techniques, and that's where you have to work with your MR technologists to just keep try a different way, maybe adjust the value a little bit here and there, and then eventually you might come up with a result that you are satisfied with.
And I think we do use like a B1000 for the spine imaging, right?
I think so. I'm not sure 100%, but I think we do use B1000.
So do you have any like a take-home point for the technologists and also radiologists about the importance of the DWI or anything that they should know or keep in mind or teaching point from this section before we're gonna finish this section?
Yeah. So like I say, so diffusion wave sequence is very powerful for stroke imaging, but it goes way beyond just stroke imaging, as you can see. So you can see that long list on my last slides that there's a lot of pathology that has diffusion, has restricted diffusion. So the point is that sometimes when you look at the image, if the clinical picture does not fit what you see on imaging, you might want to think about, because the easiest thing for us to do when we see restricted diffusion is the right way to say, oh yeah, there's acute infarction because of restricted diffusion. Most of the time you're right, but sometimes clinically that doesn't make sense. I cannot think of a good example, but there are times where I would call something acute infarction. Oh, for example, seizure. Seizure is another good pathology. If somebody has prolonged seizure, they can have restricted diffusion. Sometimes they're in the same territory as the arterial infarction. And really radiographically, you can't really tell them apart. But, I'm still going to call that acute infarction, 100 times out of 100 times. So I remember a case where I called, there's acute infarction on the right MCA territory, et cetera, et cetera. And then a couple of days later, a patient completely recovered. And then I talked to the clinical team. They said, that doesn't make sense. And I said, well, I guess another possibility then is, and at that time they didn't, I forget what the whole story was. A seizure was not something that at least initially was the clinical consideration. But later then we find out that was a cause, and then patient recovered completely. So just because a lesion have restrict diffusion doesn't mean that always is acute infarction. And also remember the timeline is very big, right? It's anywhere between starting from the acute infarction up to 10 days. So just because radiologist, as a clinician, if you see our report, it says that there's an area of acute infarction consistent with area of restricted diffusion consistent with acute infarction, that doesn't mean that it just happened last night. It could mean that it happens 5 days ago. So again, it's all a lot of clinical context. And then, and next week when we talk about, is it Dr. Ho is going to talk about tumor?
It's about pediatric brain tumor update. Mm-hmm.
Good. And that's, he's going to talk about a lot of advanced technique. And those are great to look for different type of tumor, etc. But some of the basic level stuff is still always going to be very, very relevant, including diffusion weighted sequence, which is going to be not necessarily advanced imaging anymore, but it's a concept that we still, it's very, very important for tumor imaging.
Mm-hmm. Yeah.
So, and then for the technologists, it's we really rely on, as radiologists, we depend on you to get the best images that we can, and sometimes that without your help, that really we cannot make the proper diagnosis. So it all depends on what clinical picture. Like sometimes my technologists will call me and say, "Hey, Dr. Wu, this patient really cannot stand still, and I don't know what to do." And then I would try to figure out what's the most important question I want to know. If the clinicians say that they just want to know, does the patient have acute infarction or not? Diffusion weighted sequence is very fast. So I would ask them to do the best sequence they can to go the fastest one they have, maybe do a ultra fast technique. But the most important thing that I wanted is diffusion weighted sequence. So that way they can start off right away with diffusion. And maybe because, as you know, the longer you scan the patient, the more motion the patient is going to get. So get the best sequence that you want, and then we go from there.
Yes. So we cannot be a good radiologist without good technologists. We need to work together. Right?
That's absolutely true.
Yes.
We cannot make any diagnosis. Without your help, we basically cannot do our job. So your job is equally important, if not more important than ours sometimes.
Yes. So, and I always do appreciate my technologists to call me when they scan the patient and they detect acute infarct on the images. I do appreciate on that part a lot because sometimes they alert us to read that study immediately and communicate with the ordering physician.
Absolutely, and that's great point. Is that sometimes if you see any questions that you see something looks wrong, it's always better to call us and say, "Hey, does this looks okay? Does that looks funny?" Then because we sometimes do have cases where, because clinically they don't know the patient that well and they don't have urgency, and we read maybe 3 days later we say, "Oh no, there's acute infarction 3 days ago." So by then it may be too late to treat. So for technologists, it's really important. If you see something that looks abnormal, it's please call us and just discuss. Say, "Hey, does this patient looks okay? I see on diffusion, it's bright here, dark here. Do you think this patient has acute infarction?" And I always appreciate it when technologists do that for us.
Yes, I do agree. Totally agree. So thank you so much, Dr. Wu, for giving us a wonderful talk, simplify things and show a lot of cases, and also for the interactive session. That is a lot of fun. Yes.
All right. Thanks,
Thank you.
everyone. Have a
Thank you.
good Sunday. Be safe.
Yes, สวัสดีค่ะ Thank you so much. And there was some like a technical difficulty on the Facebook Live, but don't worry because the whole video gonna repost again on the Facebook. And right now we are trying to create a YouTube channel, but I may need to consult Dr. Wu because you are the YouTuber. You are you already are
3
YouTuber.
videos only. 3
Yes.
videos.
Yes.
Yeah.
So we are going to have like a YouTube channel maybe coming soon. Right now we are trying to upload the video that we have on Facebook to the YouTube channel on the Imaging Academic Outreach Center. And I will speak in Thai. หลังจากวันนี้นะคะก็จะมีลิงก์ประเมินนะคะส่งไปให้นะคะรบกวนทำลิงก์ประเมินให้เสร็จภายในเที่ยงคืนวันพฤหัสนะคะเพื่อที่วันศุกร์จะได้รับใบ evaluate ใบ certificate นะคะพร้อม CME credit นะคะแล้วก็วันศุกร์เนี่ยก็จะได้รับลิงก์ในการประชุมครั้งถัดไปซึ่งก็คือจะเป็นเรื่องของ update in pediatric neuro เรื่องของอัปเดตใน pediatric brain tumor นะคะว่าเราไปถึงไหนแล้วเรามีเทคนิคอะไรยังไงบ้างแล้วก็มีเรื่องของ radio genomics เรื่องของ genetic อะไรบ้างที่เราควรจะต้องรู้นะคะกับดร. เชงโฮนะคะจาก Indiana University นะคะวันนี้ขอบพระคุณทุกท่านมากๆนะคะเวลาเกือบ2ชั่วโมงเต็มเลยที่เรามาอยู่ด้วยกันแล้วก็มาฟังเลคเชอร์ร่วมกันนะคะขอบพระคุณมากค่ะ Thank you so much สวัสดีค่ะบ๊ายบาย Thank you